you, Sophie and Malcolm, for that nice introduction. I'm going to now share my slides. I'm Anjali Zarkar, and I'm Consultant Clinical Oncologist at University Hospital Birmingham. And I'll go through what Saber means. So what is Saber? So Saber is Stereotactic Ablative Radiotherapy. It's also called SBRT, and it's precise delivery of highly conformal X-rays. It's unlike conventional radiotherapy, it's delivered in few treatments only. Typically, it's 1 to 3 treatments, and they're usually delivered every other day. So radiotherapy has been around for a long time, and with technological advances, stereotactic, that means very precise treatment is what the Saber is. Treatment usually is delivered every other day. And how is it delivered? So any modern linear accelerator, which is a radiotherapy machine, which is present in most of the radiotherapy departments, it can be delivered on that, or there can be a purpose-built a Saber machine called CyberKnife. So there are other machines like Gamma Knife. They do this Saber, or mainly for intracranial cancer, so within like brain tumors. But CyberKnife is a purpose-built Saber machine which delivers this precise treatment anywhere in your body. So how does the CyberKnife work? I'm going to put a small video, and hopefully that works. And it will show you this machine. You can see that there is a radiotherapy machine on a robotic arm. And unlike a radiotherapy machine, which goes in one plane in 360 degrees, this CyberKnife delivers treatment in all different directions. And I'm just going to play this small video. Hopefully that will give you an idea. So those red things, those blue things are machine is scanning, and those red bits are X-ray beams, which are used to treat a tumor within your tummy. Okay, so it can deliver treatment using lots and lots, on average around 150 beams. So that's what the CyberKnife machine, which you can see that it can basically deliver treatment to the millimeter of accuracy in a moving target, because machine is essentially tracking the tumor using some gold markers which we put in the tumor, or the, say for in today's talk, kidney, we put the gold markers in the kidney, and the machine is scanning at the same time it's delivering treatment. Okay, so sorry, that takes us to the next. So having seen that, I would like to give a bit of a background, because kidney cancer is being taught as a cancer which usually doesn't respond to X-rays, called radioresistant tumor. So there are certain tumors which respond to X-rays quite well, but kidney tumor is not one of them. But that is when treatment is delivered using conventional radiotherapy, which is smaller dose of radiation using long period of daily treatment, on average around 4 to 6 weeks. And we know that from the previous studies it doesn't work. But if treatment is delivered using large dose of radiation with less number of treatments, it is effective. And the mechanism how radiation works is slightly different. And there is lots of evidence that this treatment is effective for even tumors which are traditionally thought to be radioresistant. So what are the advantages of stereotactic radiotherapy? As you can see, it's a non-invasive treatment. So Traditionally, kidney cancer is treated using surgery, and surgery still remains the gold standard, but advantage of this particular treatment is non-invasive. You don't have to stay in the hospital. It's an outpatient-based treatment, and as I showed that it's a very precise treatment, because usually it doesn't matter whether we deliver treatment using a machine called Saber knife or even the modern linear accelerator. We do use different ways to track the tumor or reduce the tumor movement and deliver the treatment precisely. So we are able to deliver a high dose of radiation or X-rays. And as I said, typically it's an outpatient-based treatment, and it's only 1 to 3 treatments, unlike a long daily treatment of 4 to 6 weeks. It has very low toxicity, and it's really extremely well tolerated. And as I will show you later, it has excellent control rates in kidney cancer. So why do we need stereotactic radiotherapy for kidney cancer? And as I said, although surgery remains the gold standard, lots of patients are not fit for a major surgery because of lots of different reasons. Kidney cancer incidence goes up as you get older, and lots of cancers are picked up when they have what we call incidental finding. So you go in the hospital for some reason, even simple thing like tummy pain, and you have a scan, and you find along with whatever the reason of the pain was, you have a lump on your kidney, and these patients, so that's how the incidence is going up, because we are picking up more these cancers at earlier stage. And the gold standard is surgery, but because of the comorbidities, lots of patients were not surgical candidates. And even though cancer is localized within the kidney, if they can't have surgery, then the curative options are limited. So what are the alternatives? If surgery is not possible, normally these patients typically are referred for other ablations called either, you may have heard radiofrequency ablation or microwave ablation or cryoablation. It's just different means to ablate the tumor. So either you burn, freeze, or microwave by inserting needles into the tumor directly. Now, these procedures are usually carried out under general anesthesia. So you may not be fit for a major surgery, but you may be fit for general anesthesia. And if that is the case, then you're usually referred for these options. Obviously, no treatment is perfect and no option is suitable for everyone. And these techniques are not exception to that. So these usually are suitable for smaller tumors, usually less than 4 centimeters in size, and larger tumors are not suitable for these kind of ablation. Also, the location of these tumors, if they are within the renal pelvis where the urine is flowing, tumor doesn't get frozen, and that means it is not effective. If your bowel is very close to the tumor, again, the chance of this ablation, because of the proximity, may not, is, this ablation may not be possible. So, and the basic need to be able to have this is having general anesthesia, because some people are not fit for anesthesia, and that means even if the location is right or the size is correct, this may not be the option. So that's where the Saber comes in. I mean, obviously, Saber can be delivered whatever location of the tumor is within the kidney, but main advantage is it is for medically unfit patients who have localized kidney cancer, and normally, if they don't have any other treatment option, they are watched, as surgery would be life-threatening. And there are lots of studies, especially a study published by Australians. They showed in a single center, they treated 37 patients and showed this treatment is safe, effective, and feasible. And I think with aging population, with increasing incidence of kidney cancer, this Saber gives a valuable treatment option where there is no treatment option. I just would like to give you little evidence. Two important things. One is on your right-hand side, we published our experience of using this technique using primary kidney cancer, and you can see that we use both normal linear accelerator, which is available in most UK centers, as well as Saber knife platform, and showed that it is safe and effective and can be delivered in any UK cancer centre. I have to thank QEHB, Queen Elizabeth Hospital, Birmingham Charities, to fund this treatment for our patients. But also, while I spoke to Malcolm and decided this talk recently, we had Fast Track 2, again, another Australian study, which was presented in a big cancer meeting. It was they treated 70 patients and followed up approximately 4 years, and two-thirds of these cancers were more than 4 centimeters in size, means the other ablative techniques were not the best techniques for these tumors. And they showed that these tumors were controlled, local control rate was 100% at 3 years, which is excellent. That is in line with our experience as well, although we haven't had that longer follow-up. So in a sense, there is a good evidence that this treatment works, especially for patients who do not have other treatment options. So I think, at the same time, I would like you to remember surgery still remains a gold standard treatment for localized kidney cancer. So if somebody is fit and surgery is possible, then that is the option we should follow. But if somebody is not fit to undergo operation for the removal of the kidney, then usually those patients are referred to interventional radiologists to explore the option of invasive options such as I mentioned, radiofrequency ablation or cryoablation or microwave ablation. But I'm hoping in the future, Saber or SBRT may be an option offered based on emerging evidence. And we are trying really hard to get this approved on NHS. So how would the pathway work if that is an option? So I would say see a clinical oncologist who does radiotherapy, and they would go through with you the entire process of how the treatment is done, what radiotherapy planning scan is, what the side effects are, what are the chances of control, and what we're trying to do. Depending on the platform they use, whether it's a linear accelerator or Saber knife, you may need gold markers put in under local anesthesia. You don't need general anesthesia for this. This is an outpatient-based treatment. And then treatment is usually planned by oncologist and physicist, which usually takes 2 to 3 weeks. So you have a scan, then the oncologist and physicist, they work to create a plan how X-rays are going to come and enter your body and have treatment. And then everything is ready. You start the treatment, and it's, as I said, outpatient-based treatment. Depending on the size of the tumor, it might be just 1 treatment, or it might be 3 treatment over a week on alternate days. Usually I say to the patient, if you start on Monday, it might be Monday, Wednesday, Friday, and that's it. So I just wanted to show you some pictures. We treated this patient back in April 2019 using Saber knife platform, and you can see, I don't know whether you can see my arrow, but that red thing, pink thing, is the radiation dose delivered, and you can see that the light blue line, that the radiation dose is very minimal to the surrounding structure. So essentially it is this is a treatment which can be delivered without giving too much radiation to the surrounding organs, which are very close to the kidney, and the technology makes that possible. So this is just that tumor we tracked, unlike surgery where you cut the tumor and the tumor has disappeared. So if you do a scan later, you will find there is a part missing of the kidney, but here the the tumor size remains the same, or it reduces over a period of time. And I think assessing response is important, because as long as tumor is not growing, we consider that as a success. So you can see this tumor measured approximately 5 centimeters in February 2019, and that reduced to 3.2 centimeter in size over a period of a couple of years. So now I just wanted to give you an example using linear accelerator, because CyberKnife, as you can see, that as I showed you, the CyberKnife machine which tracks the tumor live, but for linear accelerator we do not have that tracking. So we reduce the movement of the kidney using different means, and here we have used a compression device which basically puts a pressure on your tummy, and that means kidney doesn't move. So using that, you can see that we've used that paddle, and that means, and then that yellow bit is the tumor, and we treated this patient on the standard linear accelerator, which is in most cancer centers. So those are the examples, and just wanted to say a few things. Is this treatment currently available on NHS? Unfortunately not, but as I said, we are working on the evidence. It is difficult to do clinical trials in this setting, and we are hoping, based on the current evidence, this treatment will be available on NHS. It's currently undergoing the process of evidence review. Yes, I think I will, without saying too many things, I would like to thank you to all my patients, because we've treated 40 patients so far, and I would like to thank them as well as their families, and most importantly, Queen Elizabeth Hospital of Birmingham Charities and our Hospital Novel Treatment Committee, who approved this treatment and funded this treatment, and our amazing radiotherapy department in Birmingham, especially my physicist colleagues, radiographers, and who have made this pathway work for our patients. Thank you.
Thank you, Anjali. It's very interesting. So we can go straight to any questions if any patients have any. So I have a question from Alison. So does it mean that if the kidney cancer has spread in my pancreas that it's not suitable?
Yes, unfortunately, because currently it is only the evidence is, well, there is no reason why it can't work, but I think if cancer is spread, you need a treatment which works wherever the cancer is. So it doesn't make sense to treat the tumor in the kidney and leave the cancer which is in her pancreas. So I think you need a treatment like systemic treatment rather than localized treatment.
Okay, thank you. I have another question from John. Is it possible to use Saber on metastasized kidney cancer in the lungs, or does the breathing movement prevent that?
It is currently, we do have evidence that if you have got kidney cancer which is being treated, and then you have it spread to the lung, but if it is 3 or less number of areas which is spread, then yes, usually this treatment works. And there are ways, again, like using linear accelerator, modern radiotherapy machine, or CyberKnife to treat these metastasis.
Thank you. I have another question from Scott. My cancer is very small and slow growing. All that is happening in the hospital is that they're monitoring me. Is it likely that trials will be available to join?
So I think, if it is, I don't know exact size of the tumor, but if it is less than 6 centimeters, then for Saber would be a treatment, but as I said, currently not funded. But if it is less than 4 centimeters, he may have an option of radiofrequency ablation or microwave ablation. But some tumors, if they are slow growing, they can be watched, and treatment is offered only when they are fast growing or reach to a certain size. If the tumors are less than 4 centimeters, usually the risk of spreading is very minimal. So you have to balance between the treatment and if the risk of spread is small, then it can be safely watched.
I have another question from Christina. How large do the metastases in the lung need to be treated?
So if the in the lung, if the metastasis is very small, it needs to be visible so that they can track. If it is really few millimeters, sometimes it can be watched, and when it is visible, then it's usually then it is treated. So I would say at least it needs to be a centimeter or above.
Geraldine, how long is it likely to be before we know if the NHS will approve this treatment?
So as I said, it's undergoing through the process of evidence review. They only, so based on the previous studies and trials, they have to, it goes to the clinical panel, and then if panel felt that this is a treatment you can offer, then it gets approved. So I would say another 6 months or so. So if it is approved by the clinical panel, we're looking at summer next year.
Question from Jeff. I have 4 or 5 secondary metastases in my lungs. Is this too many for Saber?
Unfortunately, I think so, because as I said, usually 3 or less, because you need a treatment which works on everywhere and not just 3, because it doesn't make sense to treat few and leave the others aside. So it also depends on the volume, the size, where it is, and drug treatment may be the best treatment.
Thank you. I have another question from Richard. Can Saber be used as a palliative treatment to treat pain rather than life progression?
Usually, kidney cancer tumors which are smaller in size do not cause pain, and they usually can cause bleeding, but pain indicates they are either going into the nerve fibers or there is, and I think, because Saber treatment works slowly, that may not be the best option.
Thank you. I have another question from Christina. What about metastasis in lymph nodes in the thorax? Can that be treated? Her TKI is not shrinking it well.
So as I said, the evidence for the kidney cancer which is spread, there are what we know is that if the primary cancer has been treated and then the metastasis has returned, and if there are 3 or less number of metastases, then they can be treated with Saber. But if there are too many metastases, drug treatment may be the best. It doesn't matter whether it's in the lymph gland, bone, or liver, as long as they're less than 3 in number, then you can treat them using Saber. But if there are more numbers, you need a systemic treatment which works wherever the cancer is.
Okay, thank you. I have another question. So they have 3 metastases in their lungs, all less than 1 centimeter. Is Saber a possible treatment?
I think if they're not visible, because again, it depends on the location of the metastasis. If the metastasis is very close to the heart, because of the risk, it may not be possible, but it depends on the location. And usually, as I said, they have to be slightly larger, more than centimeter in size.
Any more questions, anyone?
Mrs. Ellis.
So I was operated on for a small tumour in my kidneys about 2.5 years ago, and then I was scanned. But my last scan was a year after my operation, and has since I've got Mets, and I'm just wondering if more regular scans would have prevented that for me and anyone else.
I think it's difficult to know. It depends. Usually, the scanning protocol, it depends on the size and the location of the tumor. So I don't know particularly where it was and what was the size of your tumor. But normally, the scanning based on the risk criteria. So and you're scanned yearly. So I think it's been unfortunate that the cancer would spread if the tumor was small.
Yeah, and I guess if we'd known that at the time, if we were maybe more informed, and I'll put my hand up to being, not on the same planet as everyone else at that time anyway, but if we'd known that there's likely to be a METS afterwards, perhaps we would have pushed for scanning to be a bit more frequently rather than a year later. And it worries me that other people don't know that, and it's probably costing the NHS more, because we've now got METS, and now more drugs, more operations are needed, whereas that didn't necessarily have to be the case.
Yeah.
Thanks.
Thank you. I have another question from Phil. He's asking, is Saber effective on bone mets?
Yes, I think, as I said, those criteria, as long as it's limited, less than 3, that's the magic number, then it doesn't matter where it is, because essentially the reason is you need a treatment. You have to balance risks and benefits, and the benefits of systemic treatment, if there are more than 3 in number, it makes sense to go for systemic treatment rather than Saber. But if you got just 1 bone metastasis, then yes, you can have Saber, as long as your primary kidney cancer has been treated. Because if the cancer presents with the 1 bone met, then again you need a systemic treatment. So I think today's presentation was mainly for patients who got a cancer within the kidney, not spread anywhere, and they don't have any options such as surgical removal.
Anjali, I have another question. Someone's asking, can you ask how patients can get onto the trial?
Sorry, say it again.
How do patients get onto clinical trials?
So I think currently we do not have trial. Ideally, yes, we would like to do trial, but considering these patients don't have any option of treatment, so trial would mean treatment versus no treatment, which is very difficult to do. And but hopefully, if this treatment is commissioned on the NHS, then that treatment option becomes available, and then you can do further trials. So I think in this setting, for this indication, I think currently, as far as I know, there are no trials. But I hope this question was regarding this context rather than just how do you get on with the clinical trials. But feel free to ask if that's not the right answer.
We've got a hand raised from Ahmed. I'll unmute you, Ahmed, so you can ask your question.
Thank you so much. My question is, I went through a surgical operation, robotic assisted operation 1.5 years ago to remove cancer of grade 3 on my kidney, and that was a successful operation. However, it left me with 2.5 millimeter of positive margin. My question is, will the new treatment, radiation treatment, could be effective to treat any secondary appearing cancer, localized cancer in the kidney, if that happened in the future?
So in the future, if that, just because you have positive margin does not mean that it will grow. If it grows, and in the future, if this treatment is approved, or commissioned. As I said, currently it's not commissioned on NHS. Yes, that would be, as long as you haven't got a cancer spread and it's only within the kidney, yes, that would be possible.
Thank you, doctor. Thank you.
I have one more question. Will the NHS fund treatment of secondary lung cancer?
Yes, up to 3 areas. As I said, if the kidney cancer has been treated and then you have a secondary lung metastasis from the kidney cancer, then if there are up to 3 metastases which are not very close to the heart and visible to deliver treatment, because this treatment is very precise and has to be monitored in terms of tracking the movement, because without causing damage to the other organs, then yes, that's funded up to 3 treatments. But NHS doesn't fund if there are more than 3 metastases in time spans. Even somebody may have had 2 metastases resected and then have further 2, but total has to be 3 or less. That's the funding criteria.
Thank you. Okay, I think that there's no more questions. So thank you so much, Anjali, for giving your presentation today. It's been very interesting. And thank you everyone for joining us.
I think I've just stated, I just wanted to thank you to all of you for organizing this. Malcolm, Sophie and Hazel, thank you.
Thank you.
Thank you very much.